many of you and have had conversations with you before, and I'm actually super excited. We don't have a really huge group today because then we can have some real conversation. It also helps me because I have a holiday brain, and so it's helpful for me to not have so many states on the line. Also, this is a part of a larger project. So Sujina and I are actually privileged to get to work together on a larger project that supports organizations who are interested in adopting, optimizing collaborative care, regardless of where you are. So, please feel free to reach out to us if that's something that's helpful for you, because we're going to be kicking off a series and doing some individual technical assistance and that. So definitely reach out to us if that would be helpful for you in the beginning part of 2024. So we're going to talk a little bit about financing, and I know we've had some presentations a little bit, and I sort of wanted to try to really go into the weeds, answer some specific questions, but also talk about where we see people getting a little bit caught. So I don't think that I have to go through the model, although we always try to level set, but I think I've got some folks on the line that are pretty familiar. So we're talking about collaborative care as the evidence-based model to identify and treat patients with, actually, it's a much broader range of behavioral health conditions now. So if you're sort of thinking about, depression and anxiety, like that's great. Like our, my new friend in South Carolina there, but it's actually a broader group of definitions. We're working now with bipolar, with trauma, and essentially think about collaborative care as a population of patients that you can measure the outcomes. So using the PCL for trauma, the patient mania questionnaire for bipolar. And one of the nice things is that, particularly for healthcare organizations, it really helps you manage your behavioral health populations in a way that has outcomes, sort of like your diabetics and some of the other diagnoses. And for my friends that have joined us in federally qualified health centers, it also helps you meet some of your UDS measures for depression, and there's going to be some others coming. It can also help you, the Preventative Task Force and others have really encouraged screening for anxiety. And one of the things I think we see is that anxiety is way more prevalent now than depression. Anxiety is a huge risk factor for suicide. I think we forget that anxiety really has impact on health outcomes as well. And so as you oftentimes, primary care providers are, oh no, I have to screen for something else. And so one of the nice things is to be able to say, well, actually, we have the system in place that can really be helpful for you as we take on really talking to people about anxiety. If you remember the sort of discussions, well, we don't want to screen for depression because we're going to have all these people that are going to be positive, and what do we do? So now we can actually answer that and say, we have this, collaborative care. We really know what to do. And right since the very beginning, the research trial, we know that it works. Like I've just seen in my career how often people get better. And if people want information in terms of the outcomes now, we have them. We have them if you need them for advocacy in your own organizations. One of the things that we can work with you on is giving you some literature that supports the adoption of this model clinically. Here's how it's helpful. Here's how people get better. Here's improvement rates that our people are seeing. The other thing that we can help with is also, we've learned a lot about doing pro formas and financial pro formas. So if you're trying to work with your organization and your leadership to really advocate for collaborative care, then we can help you with a pro forma. I'll talk a little bit about it at the end, but we can actually look at what the Medicare rates are, look at your commercial rates, look at what Medicaid is doing in your state, look at, what's happening in your organization, and then we can actually be really helpful in terms of a pro forma, because one of the things that we know is that this can actually be self-sustaining and maybe even have a margin depending. And a lot of organizations are seeing a margin. We know that these codes were auto added to your commercial contracts. So as we talk a little bit more, you don't have to worry about adding them to your commercial contracts. Remember, they are billed under the primary care providers. So oftentimes I still get asked, we're thinking about doing this. Do we have to credential or professionally appoint the behavioral health staff? No. Do we have to list them with the plans? No. So really just remembering some of those pieces. Remember, it has to be billed under the primary care provider. People will often ask me, what about specialists? And so absolutely specialists. I was on the phone today with some cardiology folks. So cardiology, GI, oftentimes those can be included in here. So definitely think about what that looks like. So talked about the commercial plans. There are also some commercial plans that have some special incentives. So if you have a lot of United members, as an example, there's a pilot going on there. The Blue Cross Blue Shields have been very supportive in a lot of the states. All of the Medicare Advantage plans, of course, pay these codes. We are now actually a little bit higher than 22 states that have approved the codes. And I can certainly tell you which states have approved them, and some we're still working on. South Carolina, we have a ways to go. Nebraska, we're already there. Some of the, Texas, we're already there, minus the FQHCs, which is coming pretty soon. So really working on all of those. And so there are some states where the codes have not passed, but the payers are paying them. So places like Missouri, places like Arkansas, there are plans that say, well, state, you know what, you're a little bit behind the 8 ball, but we're actually going to reimburse for the codes on our Medicaid products. And so there are places where you're seeing that. There are also places like Pennsylvania where the plans are actually paying higher than the state actually approved the codes. So one of the things that I strongly encourage is that if you're embarking on this journey, or you embarked on this journey and you want some additional clarity, reach out to us. We can hop on a call with you, and we can go right into the weeds with you in terms of your payer mix, and I can talk to you about what specifically is happening in your state and give you some information. So definitely feel free to do that. But in the states where Medicaid is approved, you see a lot bigger uptick. And one of the things that we're learning is that in the states where Medicaid is not approved, it is harder to do something just to get providers or organizations to adopt if it isn't across their entire payer mix. But I did talk to an organization today. They were Medicaid had not passed the codes, but they had a lot of commercial and Medicare patients. And they said, you know what, we have such access problems that we're going to do it in our commercial and our Medicare patients. So just some updates. So when we talk about sustainability, there's some things that we see that are the most detrimental to ongoing sustainability. So the first is the land of perpetual launch. Some of you that have heard me talk about this. It is a cold, dark place that you just don't get out of. I've known managers and organizations that have been in the land of perpetual collaborative care launch for a decade. And so I really encourage you to avoid the land of perpetual launch. And what happens is the land of perpetual launch is that the services aren't sustainable. So not only are they the bane of your existence, but they're not sustainable. And then what happens is the organization says, well, we're not making any money. This isn't working out. And it actually goes away, or the care manager says, I'm not really getting patients. Now I'm getting other things to do. This isn't what I was hired to do. And it doesn't really take root. And so I really strongly encourage you. It is why now you will hear me say 30, 60, 90, 30 patients the first month, 60 patients the second month, 90 patients the third month. If you listen to nothing else we say, listen to that, because then what happens is your care manager has enough to get in a groove. Your billing people say, oh, I better figure this out because it's 30 patients and I got 60 coming. Your providers get a sense of what it is because there's enough patients, and generally you can be self-sustaining at around 60, which is month 2. And so really, really strongly encourage you. And if you've launched and you're sort of not there and you're kind of limping along, or you feel like you haven't got there, let us know and we can help you. One of the things is we don't really rely on those warm handoffs. Warm handoffs are nice, but they're not going to fill your entire collaborative care population. And you really want to try to do a couple of things. Think about taking some pop health approaches. Is there a report you can run with all of your patients that are on meds for depression and anxiety that aren't seeing behavioral health if you have internal behavioral health? Are there people that have scored over 10 on the PHQ-9? Are there people who have depression and anxiety on the problem list? Can you start to reconcile some of those? Are there people calling in for refills on depression or anxiety meds? Do we know how well they're doing? You know, are we automatically looping in the collaborative care folks to some of that? And really engaging the whole team and also sharing outcomes. I was in a practice the other day and they've been doing collaborative care and, you know, it's kind of not really getting enough traction. And when I met with the providers, they didn't really understand that it was really a population health approach. They were just still thinking, oh, I'm sending people to counseling and I'm just focusing on depression or anxiety patients. That is never going to have your collaborative care services be successful unless they truly understand and your care manager truly understands the treatment choices. And just as an example, we had some patients that had disengaged from services there, and we talked about a script and we had the care manager call them back up and say, listen, it's so important that we know how well you're doing. We have a way to measure, you know, how you're feeling and doing on your medication like we do your blood pressure. Is it okay that we just talk once or twice a month? I ask you some questions. We let your provider know how you're doing. All of those patients re-engage. They're in collaborative care. So are we going to talk them up when we talk to them? But what happened is that care manager really didn't understand the symptom monitoring sort of treatment choice. And so people didn't know that there was an option in terms of treatment choices. The providers didn't understand. And once everybody really understood the treatment choices, then it was much, much different. And also the providers didn't, and nursing didn't know the outcomes. They didn't know that we were looking to get people below a score of 10. They didn't know that ultimately we wanted to get people below a score of 5. And so because people didn't really know the outcomes that they were working towards and didn't really understand the treat to target approach, then it took a very different turn. When people understand, oh, wait a minute, we really have a couple of months to get these folks there. We need to rally together as a team. Then it actually changed things. And so, and that's because the largest loss in terms of sustainability for collaborative care is these, I'm going to call them not ideal things that happen during implementation. That is actually, it's not about the billing and reimbursement. I would say 80% of the time or better, it's really about the implementation and how it's going, how it's presented, and how it's launched that actually determines the financial sustainability of collaborative care. And so if you would really like to sort of go through these things, relaunch or considering a launch, this is the way to do. But we have a lot of organizations that say, you know what, we've been trying to do this for a while. We're going to stop. I'm going to rally the troops. We're going to press the go button again early in 2024. And we're going to kind of get us to where we need to be. So when sustainability comes up, a lot of times people ask about the psychotherapy codes. So technically, can you build the individual psychotherapy codes and collaborative care at the same time? Yes. Do I recommend it? No. For the most part, I don't recommend it if the codes are passed in your state for Medicaid, because a couple of things happen. One is we have a tendency then to say to people, listen, you're going to do psychotherapy and you're going to do this collaborative care thing. And when you split it like that, collaborative care almost never really works out. The other piece is that if you're going to do bill for both, you actually had to do both. And oftentimes when I look in charts, I see collaborative care happening over here and therapy happening over here. And the people who are billing the psychotherapy codes aren't actually doing collaborative care. They're sort of doing what they always do, and this person over here is doing a PHQ or a GAD, and they're not really coming together in one care plan, one relapse prevention plan. And the time that's spent on those psychotherapy codes isn't really symptom focused, sort of consistent, using the tools consistent with collaborative care. And oftentimes organizations will say, well, let's build the collaborative, psychotherapy codes because we don't have enough people in collaborative care. You are way better off to just get your collaborative care up and running with a full caseload than you are to try to mix it. Because remember, the minutes in psychotherapy count over here and you're billing them. They don't count in the monthly minutes for collaborative care. And so they wind up having to really try to make those minutes. FQHCs tend to do this sometimes because they're like, oh, we'll get our PPS rate and it's hard to make the 60 minutes over here. I really encourage you to avoid it, particularly in the beginning. If you're in a state where the codes aren't passed, then potentially you need to do this in order to make it self-sustaining, and we can talk to you. But certainly if you have a choice and your pro forma works out where you don't need to do both of these things, then I wouldn't, to be honest with you, and certainly glad to talk about that a little bit more. One of the other big questions that comes around for collaborative care are the copays. And so when you think about the copays, there's a couple of things to really think about and consider. One is there's going to be some variability with plans, right? The second is that first of year. So now we're coming into January. A lot of people have their deductibles reset. And so oftentimes then these services fall into that. So they're going to be responsible for that full amount. So oftentimes I tell care managers, tell services, remember, if you have a lot of commercial patients, then those deductibles are going to be reset and it might change the patient responsibility portion. A lot of places do have patients with high deductibles, so these are going to fall in. Remember, the good part is that because this is a monthly case rate, that if I were going to go see the individual therapist, right, I'm going to pay a copay or pay for that every single time. Whereas with collaborative care, I'm just paying once a month. And so it does actually become more affordable for the people with high deductibles, or for the people that are getting their deductibles reset. It's also another consideration that if you're doing the individual therapy codes, some people could get both copays. So remember that as well when you're thinking about that. One of the things that also comes up is that you will get individual copays for individual plans. So in other words, if I'm a specialty provider, like an OB provider, then you will also sometimes get the specialty copay. There's also a question in the chat that I'll just take now. I thought I heard to bill the psychotherapy initial assessment first, then hop into CoCM billing codes following. Is that not recommended? No, that's actually not recommended, nor is it necessary. In fact, I find it confusing to staff, Stacey, because what happens is, I'm a psychologist and a social worker. So if you tell me to do an initial assessment and bill a 90791, my brain goes to a certain place, right? And I do this big comprehensive assessment, whereas we don't actually need all that for collaborative care. So it's not required. If you look at the CMS guidance, it does say there's an assessment. It does not specify an assessment. Like if we look at the requirements for a 90791, we have to do this and this and this, right? It's pretty clear. For collaborative care, it's not clear. And they did that sort of intentionally. So when I think about what I need to, and also remember, then it's not included in the minutes. And so then you have to get 70 minutes plus the time you're spending on that initial assessment on that first month. And that's kind of hard to do, right? And it's also a lot for me as a care manager to track. And so you're better off just to start. So what do I need for that initial assessment? I need to know, first of all, how long have you felt this way? Right? When didn't you feel this way? Because what am I doing? I'm doing my diagnostic assessment, right? I'm doing some differential there. Have you ever been to the hospital or the emergency room? What's worked in the past? Oh, I saw my pastor, that was helpful. I took the blue pill, that wasn't helpful, right? So what worked, what didn't work in the past? And then I sort of move forward with care. There's actually an assessment that I designed that is really helpful for people doing collaborative care. And essentially what it does is it takes the PHQ, just because most of us will start there, and then it allows me to ask some questions that both prepare me for psychiatric consultation. Like if I answer positive on the sleep, well, do you not fall asleep? Do you stay asleep and then wake, or do you not, and then wake up? Do you not fall asleep? So that I can prepare for my psychiatric consultation. And then I also take patients who scored a 0 or a 1, and I move that over to a relapse prevention plan, and a 2 or 3 over to a care plan. And then I rule out. So if you tell me you're having difficulty sleeping, is it because you're worried about something? Right? So then I'm kind of ruling out anxiety as I go. And I ask you about eating, right? Or is your sleep related to a physical condition? Well, yeah, I'm 9 months pregnant. I can't get comfortable no matter what I do, right? And so then that tells us something. So it's actually a really nice assessment, and I'd be glad to talk people through it, but I did it very specifically because as a care manager, you need to start a care plan. You need to start a relapse prevention plan. I call it a things that work list. You need to get ready for psychiatric consultation, and you need to kind of do an assessment so that you know what you're dealing with and what to do, right? So I'd be glad to share that with you. But that was an incredibly long-winded answer of saying, no, I wouldn't do that initial 90791 unless you had to for some reason. And also what it does is most providers, most clinicians who haven't done this work, if you have them do a traditional assessment, they just launch into traditional therapy because we're asking about a lot of stuff that's not symptom focused. And so they can't help themselves, right? And actually, all my years doing collaborative care, I probably couldn't help myself either, right? I'd go down some of these other rabbit holes, whereas we really want to be symptom focused. So I would strongly encourage that you not that you not do that. And it's certainly not required. And also, if I need prior approval for mental health services, you're going to have to get a prior approval for that 90791, and then you're not going to do anything else. And that's kind of a pain. So I would just avoid that completely. I would say generally, unless you're a specialty provider, your copays are going to be consistent with your primary care copays. So if I'm a Medicare patient and I'm paying that 20%, it's going to be like $36 or whatever it happens to be. You're going to see some variation with plans. Where you see this the most is with the 99494s, those add-on codes. There are some plans who will just charge the copay for the 99492 or 3. There are some plans who will charge a 99494 copay. So I might get a copay for my 99492 and a copay for every 99494. And so you do want to be a little mindful of that as well. And a lot of them will also limit the 494s. If Medicare in particular says that there's only really 2 494s are sort of what's allowable, a lot of the plans do follow that. There's a couple that don't, like Aetna as an example, but generally I try to tell clinicians stick with the 494s with 2 of them. That's because it's just going to be a little bit more consistent. It's not going to be expensive for patients. They're going to stick to collaborative care. So that's often helpful. People will sometimes ask about waiving copays. So you certainly can waive copays. Most of the time, organizations, like I'm sure my friends at Little River do, they have a policy, right, for patients who are sliding fee scale. And so whether it's based on, 200% of the federal poverty level or whatever you have, You can certainly include collaborative care on your sliding fee scale. Because it's a monthly case rate, I actually tell FQHCs to put it separate. Like for a month of collaborative care, here's what you might pay. You could also bundle it. So like 6 months for X amount, maybe it's a 5% discount or something, or it's tied to your nominal fee. You can waive for commercial patients, but if you waive it across all of your United patients, then that's not going to be consistent with your contract. But you could waive individual ones for hardship. You just have to take that into consideration when you're doing your pro forma, which I'll talk a little bit about. What I like to do is to think about all of your plans, your commercial plans, figure out what their rules are, and then that way you can talk to patients and say, here's what it's going to look like from your end. And that's going to be really helpful. I also find that I don't talk to patients initially about the copay. Like a lot of times care managers will say, and I told them about the program, and then I told them about the copay. I don't know about you, but I would probably be out if that's how. So I never even use the words collaborative care. I just, who cares? People just want to get better, right? I just want to feel better. And so what I will often do is talk to people around like their medications and then set a goal, something that would be helpful. What's something you could do today or tomorrow to feel less sad? And then when they pick a goal, then I say, listen, you have Medicare. I'd love to give you a call tomorrow and see how that went for you. This is actually part of your Medicare benefit. It's something that's covered by Medicare, is for us to work together to get you feeling better so that you can feel less sad. Here's where you are. Here's where your provider would like to see you. And then I talk to them about the copay. Otherwise, they don't understand what it is or what it looks like. And what's the worst that happens is they set a goal, right? Or they got a little medication adherence assistance. So I wouldn't worry about it. But people have a lot more success when they talk about it after they've kind of set some goals and had a little bit of a conversation. And if people are really interested in what that looks like in terms of role playing some of that, we could do that. Just let us know and we'd be glad to hop on a call. So, one of the nice things is that the Medicare, certainly puts out their rates. So the rates are out there. There has been some literally brand new hot off the press guidance for hospital-based centers in terms of billing locations 19 and 22. That is actually fairly complicated and mostly above my pay grade, but I have the new guidance and I have learned enough about it to be dangerous. And they're actually going to be adding to it a little bit because it turns out it didn't quite solve the problem, the new guidance. And so if that's an issue for you, then stay tuned. And I would be glad to follow that up. So these are some of the codes we've talked about and certainly some of the rates. For our FQHC friends, one of the problems is that 60-minute requirement is often a barrier, especially in states that have chosen to reinforce that for Medicaid. So that continues to be an issue. And also the inability to have people in chronic care management and collaborative care at the same time. But certainly glad to talk that through if that becomes an issue for people. So these are all of the services that are included in the codes. I put them here. We've had webinars and talked about them before, but what I have noticed is that people, a lot of times care managers still shortchange themselves in terms of minutes. And, 2 or 3 minutes can make a difference between billable or not billable. So there's a couple of things that I notice people sort of shortchange themselves. One of them is really updating the registry and working in the registry. A lot of times they don't add that. They also don't include the time. They include the time for psychiatric consultation, but not the time where they've been talking with the primary care provider. So if I talk to the primary care provider or I have an exchange with the primary care provider, that's actually time that can be included. And most of the time we forget to include that time. You know, if I'm walking down the hallway and I run into the primary care provider and we have a conversation, that time is actually billable. So clarification about the pointed changes to inpatient services. So two things. The changes were actually for outpatient hospital-based sites in terms of like the professional and the facility technical billing. Here, the interesting thing is if you look at the CMS guidance, so if I had someone and they were in the hospital, I could actually start working with them while they were hospitalized in collaborative care and transition with them to outpatient. That can actually happen. And sometimes I think we miss an opportunity to engage people. I've been trying to do a lot more advocacy around having these codes included in that quality measure for hospital follow-up. The only state that does that right now is Medicaid in Arizona, but other states have not. So yeah, let's talk a minute around texting and sort of nonverbal communication. That actually does count with both patients, primary care providers, psychiatric consultants. That actually works to count towards the minutes. What you don't want to do is have anybody generalize. So every time I update the registry, it's 2 minutes. Every time I communicate with a provider, it's 1 minute. That's a huge compliance issue. You know, again, there's no collaborative care police. I round it up, you know, so if it's still like if I do something, you know, it's 12:39 right now. If I send an email message, if I have a back and forth and it's still 12:39, I put a minute, right? You know, and so really counting that time. And so those are the places that oftentimes they miss. The other is the 1/2+1 rule. And so I almost every time I bring this up, I always get a little knot in my stomach because I'm like, I just don't want to confuse people anymore than I feel like people are sometimes confused by these codes. But the reality is that there is a 1/2+1 rule, which means that for the 70 minutes for the 99492, it's 36 minutes as an example. And so most commercial Medicare and commercial plans that work, there are some places where Medicaid, it does not. And so, you know, we do need to check into that for you sort of individually, but don't forget about that 1/2+1. I worked with a practice recently and they said, well, we've never, you know, more than half of our patients don't make the minutes. Some of it was they weren't engaging people well, but the others, they weren't optimizing that 1/2+1 rule. And so just sort of remembering what that looks like and remembering to capture all of the time. You know, it does take time. A lot of times, even talking to family members, that actually is time that counts in. So really making sure that we're getting everything that we're due. So many times I hear care managers just count the time that they're spending with patients and psychiatric consultation, and they're losing a lot of minutes. So let's just think we have a way more complicated pro forma than this that we can actually do with you. And we have two different ones. So one is we're just starting out, and then we can say, here's what the caseload would look like over time. So we're going to add it up and it would be a little bit rolling. And so as an example, we had an organization that was using grant funding. And one of the mistakes organizations make is they say, okay, we got a grant. We're going to hire somebody wonderful and talented like Sujina, and she's going to be a care manager, and we're going to pay her salary. And maybe they do billing, maybe they don't, hopefully they do, but then they just leave it until the grant ends. And what I tell people is get Sujina self-sustaining, right? And then hire someone else and use the grant funds to pay for that person so that you can actually optimize the money that you're getting. And so there's a pro forma that we can do that can kind of help you figure that out. But even just sort of very basic, if you start to do the math, because I really wanted people to see kind of where this boils down. is that most of the time it's going to be higher than this. I was pretty conservative, but if you're getting $147 a month per the patient, I minus some money, which again is probably way higher than it would be to say, here's some co-pays, here's some things, you know, that aren't gonna work out. We're also gonna be paying our billing people. It's gonna be costing some money there. So we're gonna minus some money. So we're coming away with $111. Again, this is probably significantly lower than it might be. Also, we can figure out there's some organizations that contract out collaborative care, which certainly is an option. Then you keep a percentage of the revenue and then you pay a contractor, you know, who brings in the care management and some of the other pieces. But if you think about it just based on the patients, so if you have one provider, and then, you know, if you sort of do the math, right, and they have, you know, 10 patients, you're at $1,000 a month, right? If you have 10 providers, then you can start to sort of do the math. And so when somebody starts to get up to a full caseload, as an example, right, and you're thinking even about being self-sustaining, right? So if you're getting $111 per month and you're timesing it by 60 patients, that's about $6,600 a month, which when you think about salary, fringe, and overhead for a care manager, paying your psychiatric consultant, you're starting to show some revenue at that point. So if you have multiple providers, it really isn't hard for you to get to that point. And we can do a really detailed pro forma with you, knowing what we know about Medicaid, knowing your Medicare rates, knowing your commercial rates, at what percentage of Medicare you get reimbursed. There are some organizations that their commercial contracts are so good that they actually cover the cost of some of the others, even if some of them are not covered. And so really wanted you to start to just see the economics as they start to boil down. And this is just incredibly quick and dirty, but to start to show you it's really about the caseload and getting people up to a full caseload that starts to be incredibly helpful. The FTE is actually the primary care provider. So the provider FTE. So if you have one provider that has 10 patients in collaborative care, then it starts to add up that way. And again, we have way more, you know, complex things that, you know, CFOs and other folks would want to see. But essentially, I really wanted you to see how just the launch really matters and how the dollars add up. And if you have someone and they're only at 10 patients for the first couple of months, you can see how much money you're losing and how easy it is to be able to get to a point where you can have some sustainability. And so that's going to be super helpful for you be able to do. Thinking about what some of the codes are, oftentimes we forget about the 484 code. I like to think of it as the code of last resort, to be honest, because if you don't make the minutes for your 99492 or 3, then you can bill this 99484. And even though it isn't technically a collaborative care code, then you can actually use it. So if I make 20 minutes, you know, then you can certainly count that time. There are states and payers that actually don't cover the 484, like Anthem nationally doesn't cover the 484. I don't think we have anybody from Wisconsin, but they actually just passed the 484. States like New York don't have the 484 included in Medicaid, but they're not time bound. So there are some options, but particularly if you have commercial and Medicare patients, like I was talking to an FQHC recently, and, you know, they were just billing the G codes for Medicare and Medicaid in their state. And then for the commercial, but they forgot that the commercials actually cover this code as well. So they were losing some revenue based on that. And the commercials will use the CPT codes, even if you're an FQHC. Also, it always helps to throw in thinking about some of the screening codes. So I know that for FQHC friends on the line, you know, for your Medicaid, it's not going to be a bill above, right? You're not going to get paid additional, but there actually is considerable revenue in the screening codes. And so really encourage you to optimize them. So technically you can do 4 in a visit. However, no payer on this planet pays 4 in a visit. I just, you know, CMS sometimes I think does things for fun. But generally you can actually get some decent revenue. I tell you, drop it when you do it. And that way you can track, you know, what it looks like. The thing that you do need to watch is it is different with all of your commercial plans. So you do need to look at the guidelines, and we have some of them. We started to collect the guidelines for how to build a screening code. Some of them need a modifier, some of it do it so often. So it's helpful to know that, but we might be able to help you just to be able to optimize. So if you're not using the screening codes, then I encourage you to do it. We have about 10 minutes left, and I know we've been answering some questions as we go, but generally we get more questions than anything else around the launch and the sustainability. But I want to just say again, I would assume, based on where you are in terms of implementation and knowing we have like 10 different states on the line, you know, that it's going to be fairly specific. Again, we're more than happy to hop on a call, help you go through what it would look like for your organization and your state, either to do a pro forma to encourage your organization to adopt, or to help you be more sustainable, whether it's through implementation or caseload support or billing and financing. So I've done a ton of talking, hopefully answered some of the questions that have come up, but glad to take a couple of questions now.
Please feel free to unmute yourself and ask questions as well as type it in the chat if you're more comfortable that way. Yes, David.
Did I hear you correctly that you implied that the FQHCs can earn additional income from screening beyond their PPS rate?
No, not for their PPS rate. It's not a bill above, but oftentimes the FQHCs forget about their Medicare and their commercial patients, and they don't use the screening codes at all. And, you know, I had one say to me the other day, I said, well, how many commercial patients do you have? And they're like, 22%. And I'm like, well, 22% of the time you could be billing for your screening codes, and like you're not. And so that's where I see there and Medicare not in the annual wellness visits, because of course it's included there, but also in their other Medicare patients. Then oftentimes they forget about the screening codes. So that's where it comes into play. And we are really trying to advocate for some additional funding there. But yeah.
Well, I'm particularly sensitive to a bullet point in one of your earlier slides that said, don't trust the warm handoff.
Yeah, you know, I think, and it's funny because I was talking to an organization this morning, and they have 10 practices, and they've been doing collaborative care for 6 years. And they have had people in person in the practices taking warm handoffs, and they have never had one of their care managers get to a full caseload. And they're really like completely reconfiguring, starting again from the beginning. And that is because you absolutely have to take some population health approaches, right? You have to say, and I tell organizations, run a couple of reports. Here's all the people on medications. Here's all the people with depression and anxiety on the problem list. Here's all the people that have had a positive screening. Reconcile those reports, right? So you have some people that are on all 3, and then you have people that are on none of the other ones. And then I call the medication people first and say, hey, is it working, right? Yep, nope, ask them some questions. If it's in remission, that's cool. I update the chart, right? Let the provider know and we all go on our merry way. But if it's not, then they're in collaborative care. We're getting a psychiatric consultation. The primary care provider is aware. And those are the kinds of things that are incredibly helpful to be able to look at.
Mhm. Makes a lot of sense. Thank you.
Yeah.
Any other questions?
And I've actually, just to build on that, David, I've actually had entire caseloads built out of just working with nursing and the prescription line. And that if people call for their sleeping meds, anxiety meds, depression meds, then we call them back. Let's just ask you a couple of questions before we call this in today and say, wait a minute, actually doesn't sound like this medication is really working for you, right? And first of all, we find out if they're even taking it as prescribed. And then oftentimes, you have 30 of those a week in a really busy primary care practice. Well, you're a third away to building that person's caseload.
And it's real hard to get people off medications.
Yeah, and that's the other piece. Are we running a report that people have been on medications for a while? We don't want people on depression or anxiety meds forever. And so part of collaborative care can be actually helping people get off some of those medications.
Which is very helpful.
Yeah, I think people forget about that whole part of collaborative care. Yeah.
Yeah.
Mm-hmm.
Cool. Thank you.
No, thank you. I appreciate the question and appreciate you as always. Thank you, Tanya. So again, just reminding people, this is complicated. It's very specific, maybe to your centers, to your state. Please reach out to us. It's available to you. It doesn't even cost anything. We can be helpful to you. We're launching, a collaborative to really help and support people as well. So please reach out to us and we're glad to do that.
Looks like we don't have any other questions. If you do, if you think of any other questions, please feel free to reach out to me. We'll send out a follow-up email after this session today. It'll include the survey link for today's session and also going to include the slides that Verna has presented here. We'll also provide that to you. Thank you all so much for being with us throughout these series. Very happy that Verna concluded the series for us today. Verna, thank you so much for your time and this amazing session. But yeah, please be on the lookout. We'll send out more information about the program that Verna talked about, which is going to be launching very soon. With that, I'll sign off. Have a great holiday, everybody. Thank you.
Thank you. Have a wonderful day, everyone.